All right, we left off with our last section, not quite finishing section 7 for chapter 9 from the McKinley text for anatomy and physiology with articulations and specifically referring to the hip. And here we are just want to get to the basic concept for the hip joint, which is the articulation for where the head and the femur and the acetabular and the os coxa meet. And there's an acetabular or acetabular labrum, which is the fibrocartilaginous ring that deepens the socket here and helps provide that more stable, less mobile area. And it's less mobile than the glenohumeral joint by far, but significantly more stable. And take a look at this a little bit more here. Presence of significant ligaments here between the pelvis here, os coxa on this side here, and the femur itself here. This is basically an iliofemoral ligament here, the greater trochanter of the femur, lesser trochanter of the femur, and the pubofemoral ligament here. Significant band of ligaments, as you can see. And you can see, obviously, just look at the posterior view of that same right hip. The same thing with the iliofemoral ligament here and the ischiofemoral ligament here. Oh, and note here too, flexion, extension, flexion going forward hip, extension going back, abduction going away, adduction going toward. And the thing they didn't show here is if the feet were to turn in, there would be internal rotation or medial rotation, and turn the feet out would be lateral or external rotation, but the motion itself would be coming from the hip. All those motions are coming from the hip. And looking at coronal section, if the internal aspect here, the internal aspect of the hip here, looking here at the acetabular labrum here, this being the acetabulum itself, and then this being obviously that the head of that the femur here, the greater trochanter, and would be basically the less trochanter below there, and this basically here the ligament of the head of the femur, helping to keep that and maintain the attachment there. Retinacular fibers as well play a role with keeping stability at that hip joint. For support of the hip joint, then, secured by the articular capsule, ligaments, and the muscles. The articular capsule extends from the acetabulum to the trochanters and encloses that femoral head and that neck. And then these retinacular fibers, or ligamentous fibers of the articular capsule, they reflect around the femur neck, and the retinacular arteries are here. They supply most blood to the femur head and the neck. We're not going to get great detail for all the different ligaments at this time here for the hip. Now, if there's a fracture of the femoral neck, it's often incorrectly referred to as a fractured hip. Really, it's an intertrochanteric fracture. It's an extracapsular fracture, usually in younger and middle-aged individuals. There's also a subcapital fracture that occurs in the hip articular capsule. It's usually in elderly people with osteoporosis. This can result in tearing of retinacular arteries. It may have avascular necrosis in the region as well. The knee joints, the largest and the most complex diarthrosis, are the diarthrodial joints, or diarthroses, the most mobile joints, but it's primarily a hinge joint, so it's not one of the most mobile of the synovial type joints structure-wise, and diarthrosis from a function perspective with multiple range capabilities. It's capable of slight rotation, extremely slight rotation, and a little bit of lateral gliding when flexed, a little bit of motion of glide, but generally speaking, it's really just flexion and extension at the knee. To call it multiplanar at the knee would be a little bit liberal with that. It's pretty much a sagittal plane type motion joint with capacity, other than the ligaments, which keep it from getting outside that basic sagittal plane type motion. Composed of two separate articulations, the tibiofemoral joint, where the tibia meets the femur, between the condyles of the femur and the condyles of the tibia, and the patellofemoral joint, where the patella and the patellar surface of the femur meet. Now, there's a lot of ligaments here, and you will have to know a little bit of this here. From the standpoint of the quadriceps femoris tendon, here the quadriceps, of course, helping then connect with this patella here. This being the quadriceps femoris, the quads, if you will, muscle. And then basically the tibial collateral ligament here on the medial side. You're looking for the anterior here. The fibular collateral ligament on the lateral side. The patellar ligament, of course, connecting with that tibia to the patella. Patellar ligament providing stability between the patella and the femur. Just like the quadriceps femoris tendon helps supply basically stability between the patella and the femur. Also, the fibular collateral ligament will play some role here. Looking more for the posterior superficial view here, and more to this being more to the medial side now, and the lateral side being here. Or no, I'm sorry, you're still looking at it from that right knee for the posterior superficial. So we're still seeing it here. No, that's correct. I had it right. This being more the medial type side, this being the lateral side. So they get that right. The fibula is always on the basically on the medial side. So this is the medial, and the lateral side being more the tibia. For the ligaments, simply we really need to know the patellar ligament extends from the patella to the tibial tuberosity. That fibular collateral ligament helps prevent hyper-adduction, not too much movement inward toward the midline. The tibial collateral ligament prevents hyper-abduction. It basically helps connect that femur to the tibia, and it reinforces that medial surface of the joint there. It prevents hyper-abduction, not going too far into abduction away from the midline. And then the medial meniscus and lateral meniscus, they're deeper the articular capsule within that knee joint. They provide cushioning at those articular surfaces. They change their shape to conform to articulating surfaces. And they help stabilize the joint medially and laterally. A lot of times people get medial meniscus tear from excessive stress going into the medially with that knee. That knee somehow gets too much stress going medially, you can get tear at the medial meniscus. Likewise for the lateral meniscus. And then therefore, if there's a tear there, every time it gets a little bit of added stress going to the medial side or the lateral side, depending on where the tear is, there'll be significant pain, possibly needing surgery if all else fails. Cruciate ligaments, they're deep the articular capsule. The anterior cruciate ligament extends from the posterior femur to the anterior tibia. It prevents hyperextension and anterior displacement of the tibia. The posterior cruciate ligament extends from the anterior-inferior femur to the posterior tibia. It prevents hyperflexion and posterior displacement of the tibia. Okay. The ACL, you're really talking about the ACL helps keep you from going to hyperextension and the knee straightening too much. Okay, and the posterior cruciate ligament prevents you getting too much flexion going behind you, bring that lower leg behind you, getting too much motion there. PCL plays a role. And so, tibial collateral ligament injury is when the leg is forcibly abducted. The fibular collateral ligament is injured when the medial side of the knee is struck. ACL when the leg is hyperextended. And a PCL injury, the posterior collateral ligament, when the leg is hyperflexed. Okay? Less common, but does happen. Someone gets bent backward, can get a posterior cruciate ligament injury when it causes that knee to go into added extension, straining more than it's typically capable, can actually strain or particularly injure the ACL. And meniscus injury is due to trauma and or overuse in general, but it's again more medial or lateral type motion that's going to be causing that. Or more specifically, if too much stress, and so how someone lands when they run or jump or whatnot, create tremendous trauma there. And unfortunately, it leads too many professionals in some cases to say that the fault was too much exercise or too much stress. It's not that it was too much stress or too much exercise, it was too much stress in a given specific position that caused the problem, in a position that was not ideal. Because certainly if you actually use the muscle, the joint moves like it should under control, it's pretty hard to injure anything. But certainly it can be done, and people have done it. The unhappy triad is the injury of the tibial collateral ligament, the medial meniscus, and the ACL that occurs to a lateral blow to the knee that abducts and laterally rotates the leg. The talocrural joint is a highly modified hinge joint, permits dorsiflexion at that ankle, talocrural joint being the ankle joint, and plantar flexion pointing the toe away, dorsiflexion coming toward the midline, toward the shin, I should say. It includes two articulations within one joint capsule, the distal end of the tibia and the talus, and of course between the distal end of the fibula and the lateral aspect of the talus. So here we have our tibia and our fibula, okay, and the anterior tibial ligament, posterior tibial fibular ligament, and there's our talus, and talus bone there, and then the lateral ligaments helping, a lot of ligaments here helping keep stability, right? Our metatarsals, and then basically going out to the phalanges out here. Metatarsals, tarsals, and then phalanges. And then right foot is the lateral view here, the calcaneus being the heel. As far as the anatomical features of the talocrural joint, there's an articular capsule that covers the distal tibia, the medial malleolus or malleolus, and the lateral malleolus and the talus. Deltoid ligament binds the tibia to the foot on the medial side, prevents over-eversion. That's the deltoid ligament does. The lateral ligament prevents over-inversion, the opposite, preventing you from actually putting too much weight on the outside of your foot, whereas this deltoid ligament can help you preventing too much weight toward the inside of your foot when you land. A sprain is basically stretching or tearing the ligaments without fracture or dislocation. It results from twisting your foot, usually over-inversion. Usually someone turns outward, but it's not so much that it's over-inversion. That's really kind of overstating. It's really, if someone tends to, that would really be more of an over-supination technically, and a lot of sprains can occur more from over-pronation as well. But supination is a common one, and if it's inversion along with plantar flexion, that's what makes it supination at the ankle. Likewise, for pronation of the ankle, is when someone dorsiflexes and everts. Okay? It's combination motions that make it pronation or supination of the ankle. But a sprain, fibers of the lateral ligament are stretched or torn. Its localized swelling and tenderness is to the anterior, inferior to the lateral malleolus. Okay? And sprains are typically longer recovery time than oftentimes than fractures sometimes. Bones can heal easier than can some ligaments and tendons can be expected to be healing. Pot fracture occurs with over-eversion, too much weight toward the inside of the foot there. The medial malleolus is avulsed off of the tibia, that fracture there. The talus moves laterally and fractures the fibula. So what'd you learn? What movements are allowed? The temporomandibular joint, well, we didn't really talk about that, but you should be able to do that down the road. Just not crucial to us at this moment. Why is the shoulder joint considered the most mobile and at the same time the most unstable joint in the human body? What's the function of the annular ligament and the elbow joint, and what injury may occur to this ligament and joint in young children? How do the gluteal, humeral, and hip joints compare with respect to the mobility and their stability? What are the functions of each of the intracapsular ligaments of the knee joint? And what bones articulate at the talocrural joint, the ankle joint, and what movements are permitted at this joint? And then finally, explain how the three major types of joints form in the embryo and the fetus for our final section here, and describe some of the common age-related joint changes in joints, our final few slides here. From the start, the 6-week development is when joints start to form. For future fibrous joints, mesenchyme differentiates into dense, regular connective tissue, very common theme, right? For future cartilaginous joints, mesenchyme differentiates into fibrocartilage or hyaline cartilage. For future synovial joints, laterally placed mesenchyme forms articular capsule and supporting ligaments. The next layer of mesenchyme forms synovial membrane, and there's a centrally located mesenchyme that may be reabsorbed or form menisci or articular discs. For arthritis, osteoarthritis is a primary problem of aging joint due to wear and tear degeneration at a given joint, whereas rheumatoid arthritis is inflammation. It's really a hormonal response. It's an immune system response. It's really not specific to a given joint. Somebody who has rheumatoid arthritis is not going to be complaining necessarily, and usually not, of the same exact area repetitively all the time causing them problems. Osteoarthritis, when you have a problem at your finger or your hands or the fingers, it's there, it's there. And there's nothing you can do about it. It's there. You can move as much as possible to help gain lubrication and maintain as much motion as possible, but when it's broken down, it's not going to come back after a certain point. How much, there's always speculation there. The most important thing is to move however you can move and not move into pain. That said, rheumatoid arthritis is more of an overall systemic issue that needs to be dealt with as opposed to a specific joint area problem. Exercise and joint health. Exercising increases the flow of synovial fluid to the chondrocytes for connective tissue. It strengthens muscles, of course, and helps support and stabilize joints. All good things. In the extreme, however, it can aggravate potential joint problems and may worsen osteoarthritis. It can worsen any problem. Too much exercise or too much intensity of exercise can certainly cause all sorts of problems. Not enough exercise as well can do it. Finding the right balance is the key. That said, that's all we're going to cover for this, and you should now be able to note some ways that joints change as a person ages, and hopefully have a better idea on how to apply the concepts of articulations as a whole. And that is Chapter 9.